Hello everyone, in this video we are going to discuss about sterilization. It is a continuation to the chapter contraception. Sterilization is a permanent surgical contraception. It is also called as voluntary sterilization. So here surgical intervention is done unlike the other methods, and it is a voluntary method. You volunteer yourself in this, and it is a surgical method where the reproductive function of an individual male or female is purposefully or permanently destroyed. What's happening here? The reproductive system, in the males the vas deferens and in the females the fallopian tubes, both these things, they are purposefully and they are permanently destroyed by the surgical method. It is a permanent and surgical contraception. Male sterilization, that is vasectomy, the female is tubectomy. The sterilization of a man and woman is a permanent method of family planning. This method is the permanent method. Vasectomy is done in case of the males, and in females tubectomy. Let us discuss in detail about vasectomy. It is a permanent sterilization operation done in the male where a segment of the vas deferens of both the sides is resected and the cut ends are ligated. You can look in the picture here what's happening. The vas deferens of the males on both the sides, it is resected, which means it is cut out, and the cut ends are going to be tied up. Ligated is tying up. You can see the vas deferens here, both the ends, the vas deferens of both the ends, a segment of it is cut out, and after cutting it they are tying it with the thread. You can see the tying here. Okay, a part or a segment of the vas deferens is cut out on both the sides and the cut ends are ligated. Male sterilization or vasectomy, there are two methods. They are standard vasectomy or conventional vasectomy, or no-scalpel vasectomy or non-scalpel vasectomy, that is NSV. Two methods, standard and no-scalpel. In standard vasectomy or conventional vasectomy, this is a simple operation performed under the local anesthesia. So before performing this operation, we give the local anesthesia to the patient. The clamping and cutting of both the vas deferens, then the cut ends are ligated and they are folded back to avoid the risk of the recanalization. So if they are not folded, what can happen? The recanalization can occur, resulting in the joining of both the segments of the vas deferens. So what do? We are ligating and folding back of the cut ends so that the recanalization shouldn't occur. This conventional vasectomy is a simpler, faster and a less expensive operation. It is a simple method and it can be done fast and it is very less expensive. This is about the conventional. Like we saw in the previous slide, what happens? A part or a segment of vas deferens is resected and the cut ends are ligated. You can see the incision here, and then 2x wound with the stitches written for the suture removal. After then you do the transitional vasectomy, traditional vasectomy. The excision is made through each of the sides. Under the anesthesia, a part of the tube is cut and it is ligated. Then after 2x wounds, they come for the removal of the stitches. Non-scalpel vasectomy is the latest and the most popular technique. This is the latest one, no scalpel. So no incision is made. The scalpel is not used here. No incision is made. Whereas in the traditional method or the conventional vasectomy, the incision will be made under the local anesthesia. Whereas here there is no incision. The puncturing the stretched skin of the scrotal sac with a sharp instrument. What do you do here? You puncture the scrotal sac with a sharp instrument. You are locating the vas deferens, cutting and ligating the tube. You see here what happens is, with this, I'll explain you with the help of this thing. The local anesthesia infiltration. You give the local anesthesia. After giving the local anesthesia, you're holding the vas with the ring clamp at 90 degree. You can see the ring clamp here in this picture. You see the clamp, ring clamp. This ring clamp, you're holding the vas deferens with the help of the ring clamp, and your hand and the scrotal area, it should make 90 degree angle. in 90-degree angle. Then after making that, what do? You use the ring clamp and you grasp the vas deferens. After grasping the vas deferens with a ring, the skin is punched with the sharp pointed end of the dissecting forceps. You see here the dissecting forceps. With the help of these dissecting forceps, the sharp ends, you're going to make a puncture. This puncture is made with the sharp pointed end of a dissecting forceps. The puncture point is enlarged by spreading the tissues. They insert both the tips of the dissecting forceps. You see here, what do after this? You spread the tissues, and after spreading the tissues, what do? The vas deferens will be elevated with the dissecting forceps and it is holded with the ring clamp and it is punctured. This is the way you're going to perform the conventional vasectomy. Sorry, non-scalpel vasectomy. This is the method of no scalpel vasectomy. What do? Give anesthesia, hold the vas deferens with 90-degree angle with the help of the ring clamp. With holding the ring clamp, what do? You take the dissecting forceps, the sharp medial point of it, you're going to puncture it. After puncturing, you spread the tissues to insert both the tips. First, after puncturing, you spread the tissue. After spreading the tissue, you insert the dissecting forceps, then elevate the vas deferens with the forceps and hold it with a ring clamp. In this way, first make a puncture, spread the tissues, insert the forceps, hold it with a ring clamp. The vas deferens, you need to hold the vas deferens with a ring clamp. And this is how you're going to perform the no scalpel vasectomy. What are the indications of the vasectomy? The selection of the candidate, the sexually active and psychologically adjusted husbands who are having a desired number of children is an ideal one. So people who are sexually active, but then they have a good understanding, psychological adjustment is made between the wife and the husband, and the husband is already having a desired number of children. He doesn't want to have any more children, so he's going to have a psychological understanding and then he's going to opt for vasectomy. What are the indications? The family planning purposes. Vasectomy is done for family planning purpose. That is the principal indication in most of the developing countries. Like India, people opt for vasectomy. It is because of the family planning. Then socio-economic status. An individual is adopted to accept the method of vasectomy after having a desired number of children. Like how we saw here, the person who is adjusted, a psychologically adjusted husband who is having a desired number of children, is the same thing. The socio-economic conditions which will put a limit to the number of children. After having the desired number of children, people opt for vasectomy. Medical complications. When the person in relationship is having a health problem, like the health problems could be the sexually transmitted diseases, gonorrhea, chlamydia, human papilloma virus, HIV, and so on. There are so many sexually transmitted diseases that would make the pregnancy unsafe, and particular diseases which make the pregnancy unsafe. If the person is suffering from them, he opts for vasectomy. If one or both the partner is having any genetic disorder, it doesn't affect your hormone levels, nor it interferes with the sex or sex drive. So it does not affect your sex drive. Along with the sex drive, even the hormone levels are not affected here. It must be chosen as a simpler and a safer alternative to female sterilization. The complications in males are less, they can withstand more compared to the females. So it is a simpler and a safer alternative in case of compared to the female sterilization. These are the indications. What are they? Family planning purposes, socio-economic conditions, medical complications of a person, if he's one or both the partners are having the genetic disorders, as it does not affect the hormone levels and sex drives, and it is a simpler and a safer alternative compared to the female sterilization. Now let us move on to the advantages. The operative technique is simple and can be performed by one with a minimal training. So you see the person who conducts this vasectomy, it is the person who is having a minimal training can perform it. It is a very simple technique. The operation can be done as an outdoor procedure or in a mass camp, even in remote villages. You see guys, it is an outdoor procedure. A hospital stay for a longer period is not required, and it is also done in camps in remote villages. So a group of men can be like the camps can be held and vasectomy can be done in a group of people. So these are the advantages. Simple procedure. minimal training is required to perform. It can be done in camps, in remote villages. It can be done on an outpatient basis. The complications will be immediate or late. Both the immediate complication and the late complications are going to be very few in case of vasectomy. The failure rate is minimal, that is 0.15%, and there is a fair chances of success of reversal operation, that is 70 to 80%. The man, if he desires to have kids or he has undergone any second marriage and so on, if he is in another relationship and wants the recanalization, it is possible. The reversal anastomosis operation, the success rate is 70 to 80%. The failure rate of vasectomy is 0.15%. The overall expenditure is minimal in terms of equipment, hospital stay, doctor's training, everything. The expenditure is also going to be minimum. These are the advantages. Simple operative technique, minimal training required. It can be done on outpatient basis in camps. The complications are very less. Failure rate is low. Reversible probability is more, and the expenditure is minimum. What are the drawbacks of vasectomy? Additional contraceptive protection is needed for about 2 to 3 months following the operation. It is because the semen can still contain sperms for the next 2 to 3 months. So until the semen is completely free of sperms, they need to use the additional contraceptive protection for 2 to 3 months. The impotency when occurs is mostly psychological. So the frigidity or impotency in the men, it occurs because of the psychological effect, whereas the vasectomy does not interfere with the sex drive. Now let us look into the complications of vasectomy. They could be immediate complication or remote complications. Starting with the immediate ones, there could be wound sepsis, which may lead to scrotal cellulitis or abscess. You see, in the people who have undergone vasectomy, immediate complication may result in scrotal cellulitis. Guys, in scrotal cellulitis, there will be inflammation of the scrotal skin. The scrotal skin may be inflamed, associated with the tenderness and swelling of the scrotal area. So this is cellulitis, tenderness, swelling and inflammation of the scrotal skin. Or the scrotal abscess can also be formed, the fluid accumulated in the scrotal area. The cavity, fluid filled cavity in scrotum. Scrotal hematoma can also be seen. These are the complications, immediate complications. Scrotal cellulitis or abscess and scrotal hematoma. These are immediate. Now let us look into the remote complications. They are impotency. Guys, we know impotency. The vasectomy does not make a person impotent. It is his psychological thing which makes psychologically the person goes into impotency. It is because of psychological in origin. The sperm granuloma is due to inflammatory reaction to sperm leakage. You see guys, there is sperm granuloma. What is granuloma? It is a mass which will develop over a time. It is because of the body's immune reaction to the sperm leaking from the cut end of vas deferens. You can see here, it is the inflammatory reaction to the sperm leakage. A mass is formed because of the immune reaction of the body against the sperm leakage. This can be prevented by cauterization of the cut ends. So the sperm leakage can be prevented by the cauterization of the cut ends. Now we move on to the chronic intrascrotal pain and discomfort, that is post-vasectomy syndrome. It is due to the scar tissue formation. You see, there is a chronic intrascrotal pain. There is pain in the scrotum, intrascrotal pain and also discomfort. The chronic intrascrotal pain and discomfort is nothing but post-vasectomy syndrome. Post-vasectomy, after the operation, post-vasectomy, there is intrascrotal pain and discomfort. Why is this happening? It is because of the scar tissue formation or tubal distension of the epididymis. Since the vas deferens is cut, it is blocked, occluded. So what happens? The epididymis may be, the distension of the epididymis may occur. Tubal distension of the epididymis, resulting in the chronic intrascrotal pain. There is no increase in testicular cancer or heart diseases. So it does not cause a testicular cancer or heart disease. The risk of prostate cancer is considered to have no causal association. So the prostate cancer is not associated with vasectomy. The spontaneous recanalization, we see the recanalization is possible again, but then spontaneously on its own the recanalization is 1 in 2000. It is in rare conditions. Out of the 2000 patients who have done vasectomy, only one person might have a chance of recanalization. These are the remote causes. One is impotency, which is psychological in origin. Then we saw the sperm granuloma, that is a mass formed because of the body's immune response against the sperm leakage. Then we saw the chronic intrascrotal pain and discomfort, which is also known as post-vasectomy syndrome. Why does this occur? Because of the scar tissue formation. Along with this, there may be tubal distension of the epididymis. Then the testicular cancer, heart diseases, cancer of prostate is not associated. Spontaneous recanalization is very rare. Now let us move on to the female sterilization. The occlusion of fallopian tubes in some form is the underlying principle to achieve female sterilization. What is the main purpose of female sterilization? We are going to occlude. Occlude is the blocking of the fallopian tubes is done for the female sterilization. It is the most popular method of terminal contraception all over the world. The terminal contraception people, that is the ladies or the women's go for, that is tubectomy. The fallopian tubes are blocked. The female sterilization, this is complete permanent method sterilization. It is the terminal contraceptive which is popularly all over the world. Indications of female sterilization. Why do women undergo sterilization? For the family planning purposes, this is a principal indication in most of the developing countries. Like in the males, family planning, a woman, like with the mutual understanding, what she does, she undergoes female sterilization. This is it is because of the family planning purpose. Socioeconomic condition, an individual is adopted to accept this method after having a desired number of children. When she is having a desired number of children, after the last child, she undergoes sterilization. Medico-surgical indications, the therapeutic indications could be medical diseases such as heart diseases, diabetes, chronic renal disease, hypertension are likely to worsen if repeated pregnancies can occur. So guys, if the people who are suffering with, the woman, she's suffering with heart diseases, diabetes, chronic renal disease, hypertension, if she undergoes repeated pregnancies, these conditions, the chronic diseases which she is suffering from, they can worsen. So the sterilization is advisable. During the third time, repeat cesarean section or repeat of prolapse operation to avoid the risk involved in the future childbirth processes, sterilization operation should be seriously considered. Along with these chronic diseases like heart disease, diabetes, chronic renal disease and hypertension, the women who are having repeated C-section or there is a repair of the prolapse. So whenever they are having a prolapse operation done repeatedly and C-sections repeatedly, we have to advise the sterilization to prevent the risk in the future childbirths. Okay, these are the indications: family planning purpose, socio-economic and medico-surgical indications. Chronic diseases can worsen if repeated pregnancies occur. Second thing, if she is repeated C-sections or the repair of the prolapse is done, to avoid the future childbirth risk in the future childbirths, you have to advise sterilization. Now let us move on to tubectomy. It is an operation where the resection of a segment of both the fallopian tubes is done to achieve the permanent sterilization. So guys, you see here resection, what they are doing, the segment of the fallopian tube is cut. It is done to achieve the permanent sterilization in women. The approach may be abdominal or vaginal. The fallopian tubes, they are resected, they are cut out to achieve the permanent sterilization in women. It can be done by abdominal method or vaginal method. The abdominal has subdivisions, that is conventional abdominal tubectomy or mini-laparotomy. Conventional method, what happens? The anesthesia will be given and an incision is made. There are different methods of conventional tubectomy, starting with Pommer's method. In Pommer's method, a segment of the fallopian tube is lifted using the Ali's forceps. Then a loop is made using a chromic catgut. You see here, the loop is ligated with a chromic catgut and is cut about 1.5 centimeter is what they are saying. You can look at the picture here. First thing, the segment of the fallopian tube is lifted. In the second picture you see the loop is ligated. The loop is tied, and it is tied using the chromic catgut, and it is cut about 1.5 centimeter. Guys, here chromic catgut is used. Catgut is nothing but the suture. Chromic catgut, this is a modification of the plain catgut. What happens here? The suture, the wires or the thread which is used for stitching, it is tanned with the chromic salts. We tan the thread with a chromic salt. It is done to improve the strength and to prevent the dissolution of the thread. So the chromic catgut can be used, and it is cut about 1.5 centimeter. After using a chromic catgut, you have ligated it, you have tied it, then about 1.5 centimeter of the segment of the loop distal to the ligature. Distal to the ligature 1.5 centimeter, you are going to make a cut. Okay. Then you can see in the picture C, the end result of the operation. Note the wide separation. You can note the wide separation here. Hope this is clear. What we are doing in first method, Pome's method, a segment of fallopian tube will be lifted. The tube will be ligated with a chromic catgut, and it is cut about 1.5 centimeter. The end result, you can note the wide separation. Now let us move on to the next method, that is Irving procedure. In Irving procedure, the tube is ligated on either side. Mid portion of the tube is excised. So it is cut. You can see here in the picture D, what we are doing, we are ligating the tube. We are stitching, stitching up of the tube on both the sides, either sides, and the mid portion is cut. What they have given here, the medial cut end is buried into the myometrium. After cutting, what do? The medial end will be buried into the myometrium posteriorly, and whereas the distal end is buried on the mesosalpinx. Guys, what is mesosalpinx now? It is a serous layer of the fallopian tube. You can see here, it is inserted into the serous layer of fallopian tube, whereas the other one into the myometrium. The next method is Madlener's procedure. E, you can see see this picture, Madlener's procedure. In Madlener's procedure, the loop of the tube is crushed with artery forceps. You can see this artery forceps is used to crush the tube. The loop of the tube will be crushed using an artery forceps, and it is going to be tied up with a black silk. The loop is not excised. Here only ligation is done. Excision is not happening. You are not cutting the tube. You can just see here the tube is just tied, and it is crushed with the artery forceps, and after crushing it, you are just tying the thing with the black silk. So the failure rate is going to be high in this. 7% failure rate is there. This is in Madlener's procedure. Now the last procedure is Conner's procedure. In Conner's procedure, fibrectomy is done. You can see fimbriectomy. The fimbria of the fallopian tube, they are cut. The fimbriectomy is done. You can see here the ampullary end of the tube is ligated and resected. The ampullary end, you are going to ligate it, you are going to tie it, and after tying you are going to resect it, cutting it out. This is the Conner's procedure. Hope the procedures are clear. Again the names, Pome's method. In Pome's method, what you are doing? Using the Alice forceps, you are making a loop. Then using a chromic catgut, the loop is tied, and the incision is made 1.5 centimeter from the loop distal to the ligature. Then Irving method, we saw what happening in that. You are going to ligate the tubes on each side, and the mid portion will be excised. Then you are putting one into the mesosalpinx and the other one into the endometrium. Then we saw about the Madlener's procedure. In Madlener, we are not going to excise. Only the loop is crushed with an artery and it is tied with a black silk. Last method we saw, Conner's method, there fimbriectomy is done. Hope the conventional methods are clear. Now we move on to the mini-laparotomy. When the tubectomy is done through a small abdominal incision. You see, an incision is made here. When the tubectomy is made through an incision made in the abdominal wall along with some device, laparotomy, some device is used, and along with that an incision is made. This procedure is known as mini-laparotomy. Incision along with the usage of a device. The advantage is it is easy, safe and very effective in spite of the simplicity of the technique. In spite the technique is very simple, it is easy and safe. The failure rate is 0.1 to 0.5%. Cut ends become independently sealed off and retract widely from each other. After cutting the ends, they become independent. They are sealed off and they will retract widely from each other. You can see here, after cutting, the cut ends will be sealed and they are widely separated from each other. Vaginal ligation, tubectomy through the vaginal route. So you are doing the tubectomy through the vaginal route. So it is known as vaginal ligation. You see, tying up of the tubes through the vagina. The route use this vaginal route. So it is known as vaginal ligation. The procedure performed is tubectomy through the vaginal route may be done along with the vaginal plastic operation. So along with the plastic operation, vaginal plasty, along with that there is tubectomy done, or in isolation. It can be done along with the vaginal plastic operation, or alone the tubectomy can be performed via the vaginal route. When it is done in isolation, the approach to the tube is through posterior calyptomy. So guys, in calyptomy, what do we do? An incision is made through the it is a hole made in the vagina. Posterior calyptomy is done in cases of the tubectomy which is done in isolation through the vaginal route. When the tubectomy is done through the vaginal route and it is done in isolation, it is done alone, it is not associated with the vaginal plastic operation, then posterior calyptomy is the route taken. Advantages: it is a short hospital stay, it is convenient in obese women. So you see, in obese women it is convenient and a short hospital stay is advised in vaginal ligation. This is a comparison made between the abdominal approach and the vaginal approach. The surgeon can be a surgeon. Abdominal approach can be performed by anyone conversant with surgery. So any surgeon any doctor who is familiar with surgery can perform the abdominal approach. Whereas the vaginal approach can be done only by a surgeon who is conversant or familiar with the vaginal plastic operation. So reconstruction, vaginal plasty, the people who are the surgeon who is very familiar with the vaginal plastic operation is the only one who can do the tubectomy via the vaginal route, whereas abdominal approach can be done with any surgeon who is familiar with tubectomy. Time of operation can be done at any time, puerperal or interval. Whereas the vaginal approach, the interval period is most suited, may be done in other times provided the uterus is small than 12 weeks. This is the time of operation. Abdominal approach can be done at any time, whereas in vaginal approach it can be done in the interval period only, and along with that it can be done in other times, but the uterus is supposed to be small than 12 weeks. The contraindication for abdominal approach practically nil than 12 week size. Whereas in vaginal approach, if it is associated with the tubo-ovarian mass or the uterus is more than 12 weeks, it is not advised. So you guys, you see, in abdominal approach, the contraindication, the size has to be 12 weeks. Whereas in vaginal approach, if the woman is having tubo-ovarian mass or the uterus is more than 12 weeks, then it is a contraindication. Anesthesia in abdominal approach can be done under the local anesthesia, whereas the vaginal approach, the general anesthesia, whole body or the spinal anesthesia is needed. Vaginal is a very complicated, it is a high procedure, so it should be done only by a vaginal plastic surgeon who is familiar with a vaginal plastic operation, and interval period is suited. It should not be done with women who are having a tubo-ovarian mass. The general or spinal anesthesia is required. The complications during the operation are easy to tackle in abdominal, whereas in vaginal they are difficult at times and laparotomy may be necessary to rectify the complication. Duration of the operation is for a short time in abdominal. In vaginal it takes a long time. The complications are very few. In vaginal also few, but the immediate complication will be wound infection, peritonitis in the rare conditions. The late infections in abdominal are, you see, abdomen peritonitis, wound infection and peritonitis. Whereas the late will be incisional hernia, the failure rate will be less in abdominal. Whereas in vaginal, the immediate complication will be hemorrhage, revealed or broad ligament hematoma. The hemorrhage, revealed hemorrhage will be there, or there might be a broad ligament hematoma. Injury to the rectum can also occur since the posterior calyptomy is done here. So the injury to the rectum is also possible. Late complications in vaginal will be dyspareunia, that is painful sexual intercourse, and the failure rate is more in vaginal approach. The hospital stay is long, 5 to 6 days. It is short with mini-laparotomy. We saw the conventional method, traditional method is the stay will be longer. It takes 5 to 6 days, whereas with the mini-laparotomy just 24 to 48 hours. Vaginal approach, the only plus point, the hospital stay is 24 to 48 hours. Okay guys, here the comparison, what did we see? The surgeon, here any surgeon, here only who is familiar with the vaginal plastic operation. Time of operation, it can be done at any time. Here the interval period is suited. Contraindication, it is nil, 12 weeks is required. In this, if it is associated with tubo-ovarian mass and the uterus should be more than 12. Anesthesia can be given, local anesthesia can be given. Here general or spinal. Complications are easy to tackle, here it is hard to tackle. Duration of the operation will be short. In vaginal it is long. Complications, immediate in abdominal were peritonitis, late were incisional hernia and the failure rate was less, whereas in vaginal the immediate was hemorrhage and the broad ligament hematoma and also the injury to the rectum. Late will be dyspareunia and the failure rates is also more in vaginal. Hospital stay will be long in conventional 5 to 6 and in mini laparotomy 24 to 48 hours. In vaginal hours it is short, 24 to 48 hours. The laparoscopic sterilization, the last one. Laparoscopy is the commonly employed method of endoscopic sterilization. So laparoscopy is a endoscopic sterilization. The procedure is done under the local anesthesia. It should not be done within 6 weeks following delivery. Laparoscopic tubal sterilization by fist GM, that is a clip name, the fist clip. It is made up of titanium and the inner surface are lined with silicone. It is easier to apply and damage to the tube is less. So guys, you see here what basically happens in laparotomy is the tubes will be occluded. You see here the tubes are blocked. The tubes will be blocked by a celastic ring. You can see this ring which is used here is a celastic ring, and the device used is a fist clip like we saw here. Here the fist clip is made up of titanium and you can see the inner surface of the clip is lined by silicone, and it is easier to apply and to damage. It is easier to apply. This clip is easier to apply, whereas the damage to the tube will be less. This is laparoscopic sterilization. You give local anesthesia, then the tube will be blocked using a salicylistic ring, which is celastic ring, which is devised by a fist clip. Hope it is clear. Now we move on to the characters of laparoscopic sterilization. Starting with the cost, laparoscopic sterilization is expensive. It will require the adequate maintenance. Unlike other vasectomy, tubectomy, the laparoscopic sterilization is cost effective. It will require an adequate maintenance. Then you see the personnel who performs the laparoscopic sterilization. It should only be performed by persons with special training. So unlike vasectomy, with this minimal training the person can perform. In females, the laparoscopic sterilization should be performed only with people who are specialized trained. should not be done within the 6 weeks of delivery or with enlarged uterus. Now you see the selection of the time here. When you do the laparoscopic sterilization, it should not be done within the 6 weeks of delivery or with enlarged uterus. In cases of enlarged uterus, the laparoscopic sterilization should not be done. The contraindications of laparoscopic sterilization are lung lesions, heart diseases, intra-abdominal adhesions, and extreme obesity. In conditions where a woman is suffering from organic heart diseases, lung lesion, abdominal adhesions, and extreme obese women, the laparoscopic sterilization is contraindicated. Then we look into the complications, and then the hospital stay is just, the complications will be minimal. Then the hospital stay is 3 to 4 hours. The failure rate is 0.2 to 0.6%. Then the reversibility of laparoscopic sterilization is easier and effective. Only 4 mm of the tube is destroyed with a fist clip. You can see here, using the fist clip, only the 4 mm of tube is damaged. This tube is only going to damage 4 mm, so the reversibility is effective. So guys, cost will be expensive. Personal, only a person with a high specialized training is supposed to perform. The time, it should not be done during the 6 weeks of after delivery and not with persons who are having enlarged uterus. Now you come to the contraindications. A woman suffering with lung lesion, heart diseases, intra-abdominal adhesion, and extreme obesity. Then we saw the complications. These were the complications will be minimal, complications will be found, but at times these complications can be fatal. It can be life threatening. Then we saw the hospital stay was just 3 to 4 hours. It is a very less time, just 3 to 4 hours is the hospital stay. The failure rate is 0.2 to 0.6. The reversibility is effective because only 4 mm of tube is destroyed. The complications of sterilization, like we saw, the complications can be fatal, but they are minimal. So the complications could be the general complication. They will include the occasional obesity, psychological upset in women. After laparoscopic sterilization, women can undergo obesity and psychological upset. The gynecological complications could be the chronic pelvic pain, congestive dysmenorrhea, that is painful menstruation, menstrual abnormalities in the form of menorrhagia. Menorrhagia is the excessive or profuse bleeding, hypomenorrhea or irregular periods. Here menorrhagia excessive, hypo reduced blood flow, or irregular periods can also be seen. These are the menstrual abnormalities. The pelvic pain, menorrhagia along with the cystic ovaries will constitute a post-ligation syndrome. Now you see here, post-ligation syndrome, 3 things are there. One, there is a pelvic pain. Second, there is menorrhagia along with the cystic ovaries, the ovaries which are containing fluid-filled cysts. So the cystic ovaries, these 3 things, pelvic pain, menorrhagia and cystic ovaries, they will constitute the pelvic pain, menorrhagia and the cystic ovaries. These 3 things will constitute post-ligation syndrome. So these are the complications. You see, there will be obesity and psychological upset. In the gynecological, it is pelvic pain, congestive dysmenorrhea. The menstrual abnormalities are menorrhagia, hypomenorrhea. Menorrhagia increased blood flow, hypomenorrhea reduced, and there could be irregular periods. 3 things, that is pelvic pain, menorrhagia associated with cystic ovaries are the post-ligation syndrome. It is vascular in origin. The failure rate of laparoscopic sterilization. The failure rates of laparoscopic sterilization will depend upon the individual method. The failure may be due to the fistula formation. You see, it depends upon the individual methods, whereas the failure occurs because of the fistula formation, that is an abnormal communication which is formed due to the spontaneous reanastomosis. So there is a spontaneous reanastomosis of the fallopian tube. You can see here only 4 mm is damaged, so recanalization can occur. Reversibility rate is high, so the spontaneous recanalization result reanastomosis and also fistula formation. This results in the failure of the laparoscopic sterilization. The laparoscopic procedure carried the mortality rate of 5 to 10 per 1 lakh cases. So the mortality rate is 5 to 10 out of 1 lakh cases. Thank you. With this, we come to an end of the chapter contraception and the subtopic sterilization. If you like my video, hit the like button and subscribe.